Good evening, everyone. Thank you for joining us. I'm your MOASC president, Ashkan Lashkari. I have the pleasure of welcoming all of you today for the start of our 2024 lung cancer webinar series, moderated by Dr. Hatim Husain from UC San Diego. Today we have two great panelists. Dr. Jonathan Goldman from UCLA, who is the director of their clinical trial lung cancer program, and Dr. Ravi Salgia, who is the chief of the Department of Oncology at City of Hope and a lung cancer specialist. Thank you, everyone, for joining us. And Dr. Hussein, I'll transition to you to help moderate the session. Thank you.
Thank you, Dr. Lashkari, and it truly is my great honor and pleasure to be able to have this conversation today with both Dr. Goldman and Dr. Salgia on EGFR mutant lung cancer. This is a field actually that truly both have contributed dramatically into some of the standards that we now kind of adhere to and think about. And in this discussion today, we hope to kind of speak about some of the recent data that's come about. The end of 2023 had some pivotal contributions of data into this field that help us think and shape about our practice. So without further ado, actually, we're going to get started on some of this. I think just one thing to note is that in 2023 and 2024, it's perhaps not enough to say that a patient is just EGFR mutant, and really kind of understanding the type of mutation that a patient has can be really important. And this is some work that really shows that the type of mutation may change protein conformation in ways that can lead to activation of the pathways, affect drug binding, and contribute to our expectations about response to certain therapies. The most common EGFR mutations, exon 19 deletion, L858R. The next most common after that, exon 20 insertion. And then certain other mutations, such as the G719 mutations or the S768 mutations, or other mutations that can be seen, are important to note as well. The EGFR really has had a long history in terms of preclinical analysis to understand how the pathway is activated and perhaps kind of entertain potential mechanisms of resistance. We know that EGFR signals through PI3 kinase pathway and MAP kinase pathway, and there can be bypass through receptor tyrosine kinase activations through amplification and at the receptor level. This is seen over here with MET and HER2. We also know that lung cancer, and perhaps through a model of EGFR, is a plastic disease. And on top of drug selection, cancer can change. And in fact, actually really being on top and aware of the mechanisms by which the cancer is changing through therapy can be helpful in terms of how we think through some of the treatment options, whether there be resistance through the EGFR pathway, what we call EGFR dependent resistance, or bypass pathways. And we spoke about some of those in the previous slide. We also know that the mechanisms of resistance to EGFR can be important in terms of helping us kind of understand some of the expectations about how well our first line therapy will perform, and whether it be first line or second line. And this was a study that has now been published kind of many years, but I thought, for some context, this was actually important in my way and in my reference point, really understanding the fact that not all resistances are the same in both our expectations about how long patients remain on therapy, perhaps actually how we communicate about resistance to patients. So here, this was some work by Jeff Oxnard now about 5 years ago, where we can see that EGFR-dependent mechanisms of resistance through C797S This is on top of osimertinib therapy, which can drive the specific resistance mutation. Patients can end up being on therapy longer with a longer time to treatment failure than patients who have other mechanisms of resistance, such as MET amplification, small cell transformation, RET rearrangement that can be seen, PI3 kinase mutation. Maybe I'll just take a quick pause here and ask, actually, Dr. Salgia, actually, in your practice now, when you see a patient on osimertinib and a patient is progressing, does the kinetics of the progression, meaning kind of, just how the progression is occurring, are you seeing any trends in terms of your ability to kind of infer the type of resistance or, you know, if a patient has an indolent progression, does that give you a certain context on how you think about it? How are you thinking about repeat biopsy? Are you doing it for everyone? Are there certain people that you're not? How are you approaching that?
Very complex question, Dr. Hussein. I don't think we have more than an hour, right? Um, it's really very important to figure out the relative rate of progression. Where are the metastases? What's the temporal and spatial relationship? And what do I mean by that? Temporal is exactly what you asked about. How fast did this grow over time? But spatial, do you have like a solitary brain met, or do you have a solitary liver lesion? How do you take all that into account? I personally like the fact that the more information you can gather, the easier our decision making becomes. So I do tend to like liquid biopsies in our practice. So if somebody has progression, I do get the liquid biopsy done. And we have to be cognizant of the pairs. All of us are unfortunately bound by the pairs, as you know. And then the other thing is, if something can be biopsied, definitely I take a little bit of word of caution because of, let's say, if you have leptomeningeal disease or if you have bony metastases, what are you going to biopsy? What are you going to do? How are you going to look at molecular analysis? So I think all of that plays a role in my decision making.
No, thank you, Dr. Salgia. Dr. Goldman, actually, what are some of your thoughts here on when you see a patient in clinic and perhaps they're progressing on osimertinib?
I thought Dr. Salgia really laid it out very nicely. It's a very complex field. A lot of it has to do with looking at the images and what's the, is this an oligo progression? Is this multifocal progression? Is this really rapid central chest progression where you might think small cell transformation? I'd say a big area that we have many discussions about is how do we handle that progression in a multidisciplinary fashion. We certainly have a lot of debate about when it's appropriate to radiate an area of progression and stay on the osimertinib. I think that's one of the harder questions now because there's not a lot of data to guide us. But we are always keeping those other options in mind. I do think we've learned a lot about how to direct our therapy to new pathways and new resistance mutations. However, there are still challenges that even if you identify MET amplification or a RET fusion, the length of progression-free survival after a secondary treatment adjustment tends to be disappointing. So I think osimertinib remains really the mainstay of our treatment. To some degree, if you can reasonably continue a patient past progression with some radiation, perhaps that is an appropriate response. I think liquid biopsy is immensely useful. The ease of getting it and the rapidity of getting results really make it often very important, but not always so. If the patient still has generally good disease control, a lot of times that will end up being non-diagnostic. So really, I think Ravi laid it out well, and we have to keep all of those factors in mind.
Yeah. No, definitely agree with both. And, I do think in my practice, actually, as I see patients, what I would say is that some of the patients, and I've had a few patients actually that have somewhat blown through OC, like kind of just been not as responsive as I would have perhaps kind of predicted or kind of were, built an expectation around based on, published data from Flora and such. And, some of these patients do get acquired bypass pathways early. And, I think for me, it's really curious actually in reflecting on this to say that are some patients early on developing these bypass pathways as the mechanism, or some of the later recurrences? If a patient's been on OC for 5 years, then all of a sudden the patient progresses. Um, could that be more likely due to a second site mutation in EGFR? Is there any predictability or kind of question about the tempo of the resistance and how it frames what pattern of resistance?
My sense is that it's hard to make a clear one-to-one association, and that different data sets point in somewhat different directions. A lot of them are relatively small data sets, and just to get the pie chart of possible resistance pathways has required a lot of work. But I don't think that clinically it's very still very difficult to pick which are more likely. I would say, at least in my practice, C797S ends up being much less common than it seemed in the initial reports. Small cell lung cancer may conversely be more common, but sometimes we think small cell lung cancer when the patient has an explosion of disease, but we've also seen the opposite. We've seen a single lesion grow a little bit, and we biopsy it and unexpectedly see high-grade neuroendocrine cancer. So I guess getting the data remains really important.
I think the question you're also asking, Hatim, is, can we have a predictive power in the clinic to be able to do that? I think there are some circumstances where you do. So let's say if you have a concomitant P53 and an RB alteration with an EGFR, I think in your mind, neuroendocrine transformation has to occur. No question about that. If you have, let's say, non-canonical exon 20 or EGFR exon 18, the relative rate of progression is much faster in that sense as well. So I think if we were all to become AI rather than HI meaning human intelligence, I think you can pick out certain subsets where you can say, yeah, I think I know what's going on. The majority of time, I certainly don't know what's going on. That's where you need the biopsies and the evaluation.
I think it's such a great point, Ravi, that you're mentioning here. And what an amazing thing it would be to have a predictive tool to help us gauge, at least what resistance could unfold. I think this is actually the topic of one clinical trial that's being done with Helena Yu at Memorial Sloan Kettering, where I believe actually for patients with P53 and RB, based on ctDNA early in the disease course and the treatment paradigm, if there's residual ctDNA, there's an escalation attempt to add actually platinum etoposide into the on top of the osimertinib early in these patients who may have P53 and RB. So it's interesting actually how some people are kind of thinking about the kind of the research question and the paradigm and such forward. I think it's actually a very interesting point. Yeah. Have any of you had that experience of participating on that trial or kind of seeing how that is unfolding? I believe it's an ECOG study.
I'm sure we're going to talk about FLAURA2 trial, right? In those cases, and much more bulkier disease, you fear that transformation. We've always, I think all three of us really have always taken that into account and started up front with chemo plus OC. I think we all feel nervous that could there be transformation and can you delay that? I think that chemo regimen backbone we can talk about forever because we're medical oncologists, but we tend to use obviously platinum pemetrexed, not the platinum etoposide in the context of small cell, but then is etoposide necessary and sufficient for an adenocarcinoma? I don't think so, unless you combine it with radiation therapy. All of those are important questions. I think that phase 2 trial will help us as well. But at the same time, a lot of work needs to be done.
Yeah, it's so funny you mentioned that, Ravi. Today, actually in clinic, I saw a patient who has EGFR, metastatic disease, was on osimertinib, and on scans, really looks like within 2 months of therapy, cancer has not regressed as much as we want, and there appears to be some elongation of the tumor in a particular dimension, which is querying this concern for progression. And it's interesting because when I think about who to use FLAURA2, and we'll go over FLAURA2 a bit, but sometimes we think about the more symptomatic patients or people with higher bulk. But is there a time point early where, based on ctDNA clearance, that may be applicable? I really think actually that while not perhaps standard practice all the time right now, I do think that I'd be curious to see how that unfolds. My gut instinct is to say I think it could be of value, especially in this circumstance. So with that, actually, we'll just kind of move forward a bit here. So, we've spoken a bit about just the complexity of EGFR, and before getting into some of the meat of some of these trials and considerations, I think one lesson that has particularly resonated with me through the years has been that while we may label a patient EGFR mutant, EGFR mutations don't happen all the time in isolation. And in fact, actually, they can be frequently co-occurring genes, whether they be P53, CDKN2A. There can be, other pathways that are dysregulated from the time of initial treatment. And, I think some work now really is going to be in a good position to help us flesh out which patients are performing better and which patients may have more adapted treatment paradigms based on the upfront co-occurring alterations. Some data has suggested that P53 with EGFR may portend a worse prognosis. There are trials that there are other cohorts actually that the association with prognosis is a little bit less clear. At least we've done our own analysis here among our patients at UCSD, and the concomitants of P53 plus EGFR or CDKN2A plus EGFR does correlate with worse prognoses. May actually just take a quick question to ask. Jonathan, in your practice, if you have a patient where you're getting next generation sequencing and seeing some of these co-alterations, do you feel right now that there's any kind of difference of thinking that you have if a patient does have some of these co-altered genes, or right now is it kind of too preliminary, too early to really kind of inform your practice?
I think the short answer is that I feel like it's preliminary. I certainly pay attention. We are getting NGS on all the patients, and TP53 mutations are quite common. I think here you said 50%, and that correlates with my experience and our experience at UCLA. I think I do perhaps consider they might be someone to progress sooner than otherwise, but I have not taken the step to be more likely to treat them with chemotherapy and osimertinib. We did participate in the FLAURA2 trial, and we had patients do very well on both arms, and I think that makes it hard to make decisions based on your own personal experience. What I really think trials like what you mentioned that Helena's running, I think can be useful, and it may turn out that monitoring ctDNA levels could make sense. It certainly makes common sense that, and we know well that if you don't clear ctDNA, you're more likely to have a short progression-free survival, and so escalating care can be good, may be good. But even FLAURA2 gave some surprising results that it was the CNS positive patients, metastatic patients, that seemed particularly to benefit from chemotherapy, you might have expected the exact opposite. So I think really, prospective trials will be the most useful. I have been hesitant off of trial to either, give concurrent first-line chemotherapy, or thinking ahead. We'll talk about Mariposa, thinking about giving amivantamab first line. You're clearly adding toxicity, and I'd like to know that you're not just improving PFS, but ultimately overall survival, if you're going to be exposing patients to that much more toxicity.
Thank you so much, both. So the other thing that also gets discussed a bit is if a patient does develop resistance with an EGFR, and in this case, we think about C797S, whether or not that exists in a cis transformation or a transformation can be important. Particularly, some of the earlier work showed this. Ravi, are you actually kind of using this information about cis and trans and really trying to kind of sort that out? Or do you feel like it was something that came to discussion, but we just really didn't kind of materialize in terms of how to actually employ it?
I think first and foremost, majority of these reports are not really conducive to us to figure out cis versus trans. In a lot of the reports we get on the molecular analysis, so that makes it a little bit challenging. The other thing is, I think this is fantastic results, and we were quite excited by that, but we really haven't done these prospective types of trials to help us. So I actually don't use that in my clinical decision-making first. If we could go back to the last slide too, Hatim, if that's okay. I do think it's important to figure out EGFR is not EGFR, as we all know. I think if you read the John Haymack paper, what is it in Nature, in terms of the exactly what you define, Hatim, first and foremost, with Dr. Mortaza is the various subsets, be it the T790M or the XM20 or the L858R and exon 19. But I do think P53 is an important concomitant mutation, exactly what Jonathan said. I do tend to use that in my clinical practice. So there was some data that has been published and they've been reproducible, but not in a prospective necessarily fashion, but I tend to believe it, is that if you have mutations of P53 in the DNA binding domain, that's like region 100 to 300, I think, the amino acid sequence, and then you can have mutations in the oligomerization domain that's at the N-terminus. The DNA binding domain doesn't bother me as much for P53. So as soon as I see that, oh yeah, we can go ahead with osimertinib, no big deal. I mean, it's always a big deal, but not an important issue for me in my decision-making. But if I see it in the oligomerization domain, I do tend to worry a lot more, and then that's the patient I would give the chemotherapy with the osimertinib. The other one is it doesn't happen that often because that may be a mechanism of resistance, but there's innate MET amplification that can happen with EGFR mutation, and that makes a difference for us as to what to do for those patients. Do you go with osimertinib plus tepotinib as an example, or do you go with OC plus chemotherapy, get rid of those MET amplification? There are certain things I use. Then if you go to the next slide, I do think you need to gather all this data. I mean, a dream for all of us is we should combine the whole United States data like France does. Imagine the power we would have, but we're still piecemealing ourselves. And I think we need one big data set. Maybe NCI can drive us to this.
Really good points, Ravi.
Yeah.
Hatim, if I may, just adding on to that, I think I agree that actually it can be hard to tell cis versus trans, and in our standard clinical reports we often don't know. But the concept that it really drove home of multiclonality, and that some clones may have one mutation, one resistance mutation, then you get a tertiary mutation. Is that going to be in the same clone or a new clone? And you have to target them all concurrently or not? I think that concept really informs us as we think about treating a patient going forward. So I think it was a really nice highly detailed molecular explanation of our clinical experience that these tumors get more complex over time under treatment pressure.
I think that's
And I'd also I completely agree, those de novo MET amplifications, some of the patients that just blow through osimertinib are those de novo MET amp patients. And so I agree that keeping your eyes out for them can be helpful.
Yeah, that's actually, really good point. And, you're right, actually, that this type of work, really provides a clear use case and understanding about that clonal heterogeneity, clonal selection that can happen on top of therapy. So we discussed this a bit, actually, just the concomitants of P53 in RB in rates towards neuroendocrine predisposition, as well as how ctDNA clearance may also be important in terms of guiding therapeutic decisions. So now let's get into some of the trials and some of the data that had come out. I'm just going to kind of run through, some of the trials quickly, and then maybe we can circle back on, just some take-home points from these, and then go from there. So the FLORA2, here is the schema for the FLORA2, and again, the FLORA2 randomized patients in a 1-to-1 way between osimertinib monotherapy and osimertinib plus chemotherapy. Chemotherapy backbone was platinum pemetrexed with maintenance pemetrexed that was allowed. The primary endpoint was PFS by investigator, and some of the other secondary endpoints are listed over here, or our OS, duration of response. Importantly, health-related quality of life and safety, analyses as well. Here just shows kind of the demographics for the patients. I think some important points is, and important to reflect actually, that just in the beginning, again, these are first-line patients, 42, when we think about the percentages, 42% actually having brain metastases from the beginning. And here it actually shows waterfall plots. We can see pretty deep waterfall plot. If we look into some of this granular data in terms of the objective response rate, 83% compared to 76% with osimertinib monotherapy, and the duration of response with the combination 24 months compared to 15 months. Here's the progression-free survival, again, the primary endpoint, and 29.4 months by PFS by investigator compared to 19.9 months, hazard ratio 0.6. And across a variety of subgroups, it was curious to see actually that those patients with brain metastases had an improved hazard ratio compared to those without brain metastases. Importantly, there was benefit whether a patient had exon 19 deletion or L858R. And that's actually shown over here, where we can see that compared to osimertinib monotherapy, the addition of chemotherapy, even for a subset of patients with L858R who historically have underperformed compared to exon 19 deletion, these patients actually did better with a hazard ratio that was in the same range as the exon 19 deleted patients. And here actually shows the data with those patients with brain metastases, really a hazard ratio quite impressive of 0.47 with those with brain metastases compared to 0.75 without brain metastases. So there was an analysis to look at the second progression-free survival, again, after therapy, after this first line. What we could see actually with that is that patients who receive chemotherapy in the first line, upon second line, is with the additional subsequent anti-cancer therapy, there appeared to be still important PFS2 that was seen, hazard ratio of 0.7. The overall survival hasn't really matured as yet, not reached. And so again, we'll have to see how this unfolds. Here's just some of the safety analyses. And I think some important points are the rates of discontinuation. any AE leading to discontinuation. And again, this includes the maintenance pemetrexed, 48% for any AE. If we look at what type of discontinuation, it's listed over here in the further breakdown. Again, most common AEs noted are cytopenias as well as diarrhea and nausea with the combination. So we'll just take a short pause over here. And Jonathan, actually, what are your thoughts about FLAURA2? Has this data informed any of your treatment decisions? Have you used FLAURA2? You were investigator on the trial. And how, kind of what is, as someone who actually, participated on the trial here with this, any pearls or things you can kind of provide us based on your experience?
I think you covered really all the main points. I think you do get the increased toxicity, but about 10 months improvement in progression-free survival. I think my patient that is still going on treatment is now 3+ years of getting pemetrexed every 3 weeks, but she looks wonderful. She ran the marathon actually in New York. Pretty amazing. And so that is very gratifying. I do wonder very honestly what to make of the OS situation. Yes, it's somewhat immature, but they're really overlapping, and really in the end, that is what we want our more aggressive therapy to do, to lead to someone living longer, not just spending more time under toxic drugs. And at the same time, when you're looking at a first-line therapy, and there's therapies beyond that, benefits may not always become apparent when you're looking at OS. So I'm still struggling with trying to understand this. I do think, as I'm sure you're going to get into, the same question of PFS versus OS benefit is coming up in many of our trials right now, and so I think that we'll have to think about it carefully. Certainly, it's important to talk to patients about it, and there are some patients that will say, I want to be as aggressive as possible, and in a younger patient, that may be a clear choice. But many of our patients are in their upper 60s, 70s, 80s, and 90s, and they're, I think I'm hesitant to give the toxic chemotherapy until it's needed.
May I just ask a quick question about that? So, like, say you have a patient who comes in tomorrow, and firstly, would you ever use FLAURA2 before FDA approval? It is now adopted into the NCCN guidelines. That was as of this month. It has been included in the NCCN. Are there certain patients that you would consider FLAURA2 for right now?
I think, well, I guess it's sort of, not that age is the most important factor, or only factor, but anyone that's under 70, I'm bringing it up as a possibility. I really do try to focus on the fact that beyond actually the toxicities that we measure, there is a toxicity of just coming into the office every 3 weeks. The time that takes them away from their family or their job or traveling is an impact. And it's hard sometimes for patients to think of that when they're so terrified about this diagnosis. But I do try to talk about that as a real toxicity of chemotherapy. And honestly, up till now, no patient, regardless of age, has said that I want to get the chemotherapy based on what you've told me. But I'm sure there are patients that would, but not as of yet. I haven't used it. I think that the data that we have, our experience with chemo and NCCN support, I think all would, to me, mean I don't think we have to wait for FDA approval. But nevertheless, I haven't done it off trial.
And Ravi, I may ask you the same question, actually. In your clinic tomorrow, if you have a patient coming in, is there a specific patient profile that you would think about this, or, kind of what are your thoughts here?
First and foremost, kudos to the FLAURA2 and investigator Jonathan, you as well. And there are a lot of questions that arise in FLAURA2. I'm going to go over those questions first before I say, what do I do in my practice? Overall survival hasn't really been read out. And if you look at this diagram here, I think OS has only been read out for about 30 to 35% of the patients only. So that's an important one to keep in mind. So we are excited about the OS readout, just like for early stage disease, where in OC, OS was not read out. And really the disease-free survival was read out and so forth. So we had to await that in that sense, but it was quite impressive. That was one. The second thing is that, is there not a difference or a difference between L858R and exon 19 deletion? I think L858Rs do a little bit worse than exon 19 deletion, but I think you have to subset out the exon 19 deletions too, the 747s versus the 757s, exon 19 deletions with the P53 and the oligomerization domains, like I just talked about. I think those concomitant mutations weren't taken into account per se at all. Then we have other things about the CNS metastasis that's quite impressive, and I like that data set. So I do think FLAURA2 is here to stay. So what do I do in my practice? So today was a huge clinic day, right? And exactly what Jonathan said. We talk to our patients and then say, we could start the chemotherapy, but it's a long-term commitment. I mean, unlike our immunotherapy as an example, where we have potentially a stopping rule at 2 years or 35 cycles, right, for metastatic disease. We don't really have a stopping rule. How far can you go with pemetrexed? If you look at the Roswell Park data, can you give it Q3 weeks versus Q4 weeks to make it better for your patients? But it's still pain for somebody, let's say, if we're in Duarte here and they're coming from Antelope Valley, I'm just making that up, right? So, but that's a lot of traveling, but is that really worth it without truly substantial benefit? But the PFS is significant, what, 25 months versus 18 months or something to that effect, right? So I think we await the data. So what is the patient population that I would say I'd be very encouraged, and I already do that in our practice for a while already, that bulky disease is important, that concomitant P53 mutation, the P53 with the RB mutation. So I cherry-picked when we're going to do that, but I don't do that for everyone. There's no standardization. I mean, there's standardization within our own group itself, but we would love a standardization within the world, and we await that further data to be able to do that. And I think you're going to see a lot of letters to the editor over time, I suspect, in the New England Journal, right? Where all of these questions will become very relevant. We don't have the answers, but I do think we need to continue getting the data and doing more trials.
I think really good points. And I think in my practice too, is if there are patients who have big bulky disease or symptomatic disease, I do think about, at least, kind of consider chemotherapy as well, at least offering it to them if they are open to it. Okay. So along those lines, the strategy now after the first line is quite complex. And some of the earlier, I guess, very interesting paradigms that were being established was based on the type of mechanism of resistance. Can we adapt the treatment based on that? This was represented in a study called the Orchard study, still ongoing. There are many arms. One arm that's not included on this diagram from 2021 includes a BRAF mechanism of resistance with a MEK inhibitor that's included at that point. It's going to be interesting because we're seeing so many kind of routes on how to deal with resistance, or at least kind of work with it. May I ask you, Jonathan, actually, in your practice now, we have almost like a competing algorithm here of, do we get better granularity on the mechanism of resistance and adapt the treatment for that perhaps genomic mechanism of resistance? Or do we take like a one size fits all and kind of think about more of, a type of therapy that could be more embracive, perhaps chemotherapy, perhaps an ADC? Do you see the field kind of moving in a particular direction here?
So, great questions, and I think really goes across all our different targetable mutation cohorts of patients. Um, the I We are also participating. I'm participating in the Orchard trial, so that was one way that we took care of patients before Orchard was fully open. I had this patient that I think was really demonstrative of this possibility. She was on osimertinib for a while, then had progression, had a RET fusion, added in selpercatinib, had another great year, then had progression, and then had a secondary uh, uh, um, solvent front mutation in RET. So then went on to a second generation RET inhibitor with osimertinib and had another response. Right. But each one was shorter and shorter, and there was the scientific excitement of it, but I don't know that it was all the way matched with the clinical benefit all the way through. And she got chemo along the way also, and there was nothing really left on the table. But I do think that you'll see, looking at the Orchard data, there was a lot of people screened, and many were unmatched, and so there's a lot of work to find those few patients with those, C797 or RAF fusion or RET fusion, and I think we're still learning whether it will be beneficial. I think in the end, what probably we'll have to do is figure out how to be aggressive up front. It's mostly been upfront therapies that have really transformed outcomes. Actually getting back to your initial question, can we predict what the resistance will be? It may be that at really low levels, you can identify the future resistance mechanism up front and target that up front. But I think that there are some great examples, but it's hard to, and I do look for it. And if they have a MET amplification, I love to add in a MET inhibitor. But you also have to don't forget about chemo. Really, that can be the solution that gets the patient out of trouble.
I really loved how you reflected on that point around the hit rate, and yet really kind of being clear, because there are some examples of people who really have derived benefit from.
Yeah, and maybe that ctDNA is the best solution. Then you'll know quickly, and if you don't have a great target, then you go to chemo. Although you list the transformation that way. There's a caveat to every suggestion. Sorry.
Well, thank you. And
I've always Jonathan, if we can talk translational science, I wonder. No, that's exactly right. I love liquid biopsies, right? Cell-free DNA, and could we go back in time like the breast oncologist did and then looked at circulating tumor cells? And could we identify in those circulating tumor cells any neuroendocrine markers? I'm just saying that out loud. No one has done that. If somebody's interested, we should do it. And then could you say, okay, coming back to the EGFR resistance, P53, RB, in the cell-free DNA, and all of a sudden you caught a neuroendocrine cell circulating. And so just like your breast oncology, what we used to do is all those CTCs, you remember in the old days, and even for small cell lung cancer, we used to do CTCs. A long time ago, we had an R21 in the 1990s. That's how old I am looking at CTCs. I wonder if in the future we can build that into our research portfolio and say, maybe we don't need to do the biopsy. I'm just thinking out loud. That's all.
Yeah, no, I think great points, Ravi. And I think, really this adaptive treatment paradigm, I'm really curious to see how Orchard unfolds when it's fully mature, because it really has, generated, and this was one of, at least to my knowledge, one of the larger efforts to come up with a biomarker match strategy at the point of resistance that is iterative. And hopefully it is successful in terms of at least execution, to be able to figure out if this type of strategy can apply across other drivers as well.
But there's also that Empower study, right, with the carboplatin, taxane, atezolizumab, bevacizumab. That does work for our patients, right? It's a pretty toxic regimen, but it works. But if you look at the Cleveland Clinic data where they did carboplatin, pemetrexed, atezo, and bev, I think, it didn't work at all as well. So it's the backbone and how you choose the backbone as you go forward, if indeed you have no match. I think all important, and I think I'd like to use the MOASC platform today to come up with some revolutionary concept that I'd like to present in a slide if we get time, to say we need to go beyond all of this thinking. And I'll present that one slide.
No, thank you so
I'm
much,
teasing
Ravi.
you at them. I'm just teasing you. Yeah.
Yeah, no, we will go, we will go there. Actually, just want to round up this discussion with this tug of war now, looking at, therapies that are being investigated in the resistant post-progressive situation. Amivantamab at ESMO last year, the MARIPOSA-2, looking at the combination of amivantamab plus chemo, amivantamab lazertinib plus chemo, compared to chemotherapy. What we saw was really kind of interesting data that amivantamab improvement in PFS compared to chemotherapy, and improvement in intracranial response as well. And I thought that was very curious. The data actually seems to suggest that amivantamab plus chemo performed, pretty similarly to amivantamab lazertinib plus chemotherapy. In fact, actually in the trial, there was, amendments in the protocol to really kind of figure out how to approach the lazertinib arm around toxicity, as well as when to initiate the therapy. Also, the Herthinia Lung 01 study, again, this is looking at antibody drug conjugate, anti-HER3 deruxtecan antibody drug conjugate, patritumumab. What we can see over here, response rate of about 30%, duration of response 6.4 months, and PFS about 5.5 months. In this study, also some element of intracranial response. And really interesting, actually, we're seeing this paradigm about ADCs having some intracranial response, albeit not, on the same level as, say, monotherapy osimertinib in the beginning, but perhaps kind of about 20 to 30% response rate in the CNS, in disease control, about 80%. The Tropion Lung 05 study, again, this is looking at datopotamab deruxtecan and there was, in this specific study, looking at what's called the AGA population, the actionable genomic alteration population. Some interesting points to note over here is EGFR patients having a response rate in the range of about 43 to 44%. ALK patients doing a little bit less, well, but 23.5%. In this AGA population, the ORR as it pertained to the eligible included patients were about 35.8%. Some key AEs to know with datopotamab, oral mucositis, there can be some ocular toxicity, infusion-related reactions, and a low rate of ILD. So with that, actually, we spent a lot of time speaking about the exon 19 deletion L858R. Just to round out, amivantamab is FDA approved as a subsequent treatment option for EGFR exon 20 insertion. This is built upon the Chrysalis clinical trial. Here it actually shows response across the diversity of EGFR exon 20 insertion events. There can be over 70 different EGFR exon 20 insertions, really kind of necessitating next generation sequencing as a preferred method of identifying these specific alterations. And at ESMO presentations of amivantamab plus chemotherapy, this has been adopted into the NCCN guidelines. Largely, this combination yielding an improvement in PFS compared to chemotherapy, 11.4 months compared to 6.7 months, and higher response rate, 73% compared to 47%, and landmark benefit that's seen across 12 months, 18 months, and 24 months. So with that, actually, just some final reflective points, actually, and then we'll maybe speak about some of the clinical trials that are happening at our individual sites. So Ravi, actually, based on this final, kind of bit of information that I've presented about the ADCs, amivantamab, have you in your practice used amivantamab as a subsequent therapy option? What has your experience been so far?
Yeah, so I'm going to have to start by being a little bit cautious here. 4 to 6 months of PFS is not good enough. I'm sorry. And the toxicity you gain from all of these ADCs and or a bispecific antibody with the amivantamab, EGFR, and MET, they're pretty toxic drugs. And that's been our experience to get our patients through this in the context of having such great responses up front, let's say with osimertinib or OC plus chemo, and then to give them toxic regimens. I think we have to do better with the toxicity and better with the PFS, and even ultimately exactly what Jonathan said, the OS, even in second line, third line, however we want to deal with this. So yes, we've had experience with amivantamab on trial. Yes, we've even got some usage ipso facto, a trial that is just for clinical use. I think we can't really get lazertinib in this country, so that becomes a little bit much more challenging. And even if you go to the international offices, they can't really deliver the lazertinib to our patients. So do you do amivantamab plus osimertinib? I'm not sure, but I've seen a few consultations that a number of other investigators or other people who I've seen in consultation have done that outside of this institution. I think we have to continue this, but I would be very critical here. It's not good enough, is what I would say.
Hey, Jonathan, your reflections here on that point. Have you used amivantamab as subsequent therapy, and what do you think about where the field has moved?
So I think all of those points were excellently put. For EGFR exon 20, I think that it is a nice drug and better than mobocertinib in my, from the data, and moving it in with chemo, since they're already coming in for first line chemo anyway. I found that to be a pretty reasonable regimen. And I think moves the field forward for exon 20. We have these great new TKIs that are coming down the road, at least 3 that look pretty promising for exon 20. So it may be that the order gets shuffled around and we start with the TKI, but then when we go to chemo, my impression is that amivantamab is adding meaningfully to chemo for exon 20. For exon 19, I had the same concerns with first line amivantamab as I do with FLAURA2, that you're tying the patient to come in. The toxicity of amivantamab is real, especially with the TKI in addition. And there's the rash, there's a peripheral edema, hypoalbuminemia. There's a subset of patients that really get very problematic anosarca, and it limits their activity quite meaningfully. So I don't see us moving towards first line amivantamab based therapy, but I think in the second line with the chemo, that arm looked reasonably well, reasonably good, and it is, I agree that it's a current option on progression on osimertinib to add amivantamab. It's not something that I've done more than once or twice, and I'd certainly like to look for other options beyond that.
Has the inclusion in the NCCN guidelines, has that influenced any of your thinking or strategy in this way?
I think that's for the Papillon, right? I don't think they've included Mariposa, or
Actually,
have they done that also?
I believe they included Mariposa as well.
Okay, so I'm as I said, I'm relatively happy to look at Papillon for my patients, but Mariposa, either one or two, I haven't yet.
And I'll double check actually the NCCN. I had thought that was the case, but I'll double check actually for anyone. Yeah. Well, good. Well, thank you so much. And now, actually, what we're going to do is I'll turn it over, Ravi, to you, if you don't mind, maybe sharing your screen with the slides, and we can just do a quick kind of review of the trials that we have going on.
It's okay. Can you see that? I just wanted to emphasize a point here. And you, brilliant. I love talking to both of you, right, Hatim and Jonathan, and thank you for inviting us and so forth. It's always something we learn, but we also text each other a lot. So we learn from each other that way too. I mean, you've already talked about the various, here's where the revolution has to occur over the next 5 years, if you really ask me. You know, in my mind, only 50 to 60% of mechanisms of resistance, even in EGFR TKI, is genetic. The other ones that you showed and why we can't find it is they're non-genetic mechanisms. That's the new revolution in science and medicine for us in thoracic oncology. So I think non-genetic, you already know in terms of this cell phenotype and the plasticity. We talked at length about the small cell and this whole EMT, epithelial mesenchymal transition. So on the left of this panel, we've all talked about all of these things, right? In terms of looking at the various mutations. But I really want us to pay attention as we go forward for the future in designing clinical trials. It's not about a MET amplification, it's about a MET overexpression. It's about the hepatocyte growth factor overexpression and or being secreted into the blood, that you have to think about it as a biomarker. AXL is an important pathway as well, but AXL is not mutated nor amplified, but it's actually overexpressed. There are non-genetic mechanisms of transformations and non-genetic mechanisms of resistance that are related to methylation, phosphorylation, so post-translational modification of proteins, so phosphorylation of certain proteins, downstream signaling from EGFR or other pathways themselves are going to be important. Glycosylation is important. So I think if I was thinking about this from the company perspective or from IIT perspectives, investigator-initiated trials perspective, I think we should do these biopsies. We should do the next-gen sequencing, no problem. We should do the FISH or amplification fusions and so forth. But I also think we should do non-genetic mechanisms. And that's where we're putting a lot of our time and effort here at City of Hope, beyond just the genomics. And we all know, I mean, we need to create the better drugs, the newer drugs. I mean, all of us work in the immune therapy space as well, beyond the targeted therapeutics. And it's nice to see, let's say, 20 to 25% of our patients, 5-year survival or even more, depending on our data set. We want that for our patients here too, even though a lot of our patients survive way beyond 5 years, no question about that. So here are some of the trials. I won't belabor the point, but just to be able to say, we need to create many more trials. But I think the revolution for me for the future is really this whole, not only genetic mechanisms of resistance, but the non-genetic mechanism of resistance. I'll stop sharing because I want to hear Jonathan as well.
Thank you, Ravi. It's so impressive.
That looks great. Yeah, very, very exciting. I think we are also, have those concepts in mind that we have to have lots of different directions for our patients. Some that are really, shooting for the stars type approaches. We CAR T trials, TIL trials that still need some research and development to implement and to really identify predictors of potential benefit. But I think I agree. Our patients are not looking for 3 or 4 months. They're really hoping to be able to have meaningful years. And with that in mind, how do we want to design and strategize with our trials? Hatim asked me about one of the investigator-initiated trials we have. It's reusing approved drugs. It's osimertinib, nesituzumab, and trastuzumab, based on work from the lab here at UCLA, also with Dr. Yarden at the Weizmann Institute in Israel, showing actually along the lines of what Ravi was just talking about, the phenotypic changes in the cells, decreasing phospho-EGFR, but also AXL, phospho-AKT, and trying to demonstrate that we can cause the cells to behave differently based on these cell signal modifications and inhibitors. Many of the trials that we're running, we've alluded to savolitinib trial, a patritumab trial. We have a few ADCs, which I agree with Ravi, we're getting months out of, but what can we do to really get a home run with them? It's not clear yet. There are some subsets that we also talked about a little bit. In addition to exon 20, now this term that I'm hearing more and more, at least the PAC mutations, a grouping of some of these rare mutations. Are some of these newer drugs like furmonertinib going to be more effective than either osimertinib or some of the more toxic but effective second generation drugs like afatinib? Is a new generation going to make a difference there? But I think, exactly like Ravi said, working together, we have this great community in Southern California, all the way up and down, and referring patients, thinking together has been one of the great joys of practicing in this field.
Thank you both actually for that. That really is something that I have really cherished as well, is just having such a welcoming community for lung cancer advancement and practice, really kind of learning from each other. And that's why I love speaking with you both actually about EGFR, because I learn so much each time we do this. So with that, actually, Dr. Lashkari, I'll turn it over to you and for some last words, but really appreciate everyone in the program today.
Well, thank you guys. Thank all of you, Dr. Salgia, Dr. Husain, Dr. Goldman. I really appreciate all of you guys being here. I always learn a lot. I think our audience always learns a lot. I think beyond just you guys being able to communicate with one another, I think you guys make yourselves very available for the clinician who is seeing a lot of different types of cancers, may not be just seeing lung cancer alone. And I think that helps tremendously, because what's so apparent is that when you're within the field of lung cancer itself, even if you're in just this small area of EGFR mutated lung cancer, it's like opening up a whole new book of so much that we don't even know when we think we know everything about it. So it obviously, it's very humbling for us, and I think it just kind of adds to how complex things are becoming. But at the same time, as liquid biopsies become easier to obtain, and the information easier to dissect and analyze and be able to share with you guys when we have questions, certainly, and having more trials, I think that certainly is very helpful. So it's every time we schedule this particular lecture, I always feel, or this webinar, I feel like we're just scratching the surface and we're just learning a little bit more each time. So thank you guys all for being here. And MOASC really appreciates your efforts, and we'll see you guys soon. I appreciate it. Thank you once again. Have a great evening.
Thank you. Have a great week, everyone. Bye. Bye.
Thank you.